We're here for you and for your loved one. I am a nurse practitioner. I'm adult gerontological acute care certified. Just means I like sick little people. That's my easy way of saying it. I have a little bit different approach. I like to break things down to where it's not ununderstandable. So if at any point if I say something that doesn't make sense or that you'd like me to elaborate on, don't hesitate to ask, okay? So, we'll get started. Throughout my presentation, I've chosen to put pictures of hands because I feel that the power of connection is very important as you're caring for someone with dementia. Always remember that connection on a human level, on a one-on-one basis, is of utmost importance. It doesn't matter if your loved one is still walking, talking to you, following commands, or if they're in the bed and they're unable to do anything. This is what's important, is that physical contact. They need that, and you need that too. Some of these slides I'm going to kind of go through a little fast because Dr. Keller has told me y'all have gone through this in some of the other courses. But with normal aging, things to expect are things like changes in taste, smell, vision, hearing, and recall of known facts, such as, where did I put my keys? How do I get from the grocery store back home if this road is blocked off? That's in some mild dementia. You'll start seeing that. Now, for a while, in other ways, where you may not know that, but as the dementia progresses, you'll start seeing it very, very vividly. So then you know there's a problem. When you know there's a problem, because you start seeing this, that's when you generally go to your doctor and say, hey, you have a problem, something's wrong. Dementia is cognitive brain failure. Just like a heart attack, you're having a brain attack. And I will say, I stole that phrase from Dr. Gahan. But it's very appropriate. And it helps you understand what's going on. Your brain is no longer working. You have a problem there. You begin to have declines in both social and occupational functions. So you can't interact with your friends like you did before. If you go out and try to have a glass of wine, that doesn't happen like it did, because now you may start seeing some behavior changes. In late stage dementia, those interactions are much different, as I'm sure y'all have recognized by now. I like these two slides. They're able to show you that as your brain begins to change, look at the neuron. Look at a normal neuron and how it's actually declining. And then look at the CT and the PET scan. These tests are important, but they don't change how we treat your loved one. So at some point, it gets to where these tests are no longer the focus of our treatment. Our focus is hands-on care, love, and affection. They're no longer able to compensate for their deficits by writing notes, such as remembering, okay, I need to buy bread and eggs. This is still moderate. Family and friends do begin to notice those declines. And every person's journey through dementia is different. You can't compare Aunt Sue to your mom. They're going to be very different. They may have some similarities, but they're not going to be the same. Any of you found that to be true? I like these pictures because each one tells a separate story, but they're all true. And you can find similarities with each person if you look long enough. This goes over the different types of dementia and just very briefly tells you the percentages. Now again, these estimates are probably very underestimated because we don't know exactly how many people have dementia, because you really don't diagnose it early enough or for whatever reason, you don't present, you don't get on medicine, you don't get the treatment. But these are rough estimates. So you see Alzheimer's is our main type. These are some differences between the different types and how you may see that they change with each type. But individuals may share characteristics from more than one type of dementia based on their other comorbidities, such as heart disease or diabetes or vascular disease. Many caregivers do find that it is challenging to understand the differences. And well, why can't you fix this if we know this is what's causing this? Why can't A plus B equals C? It's not that easily done in dementia. Advanced or end-stage dementia, which is what we're going to talk about mostly tonight. They have a progression of these symptoms. They are very dependent on others for assistance in all areas. They're typically unable to stand or transfer from a bed to a wheelchair or feed themselves or toilet themselves or communicate their needs to others. So that's why a caregiver is so important, because you're their lifeline. Excellent supportive care rather than additional medication is often the preferred treatment for patients with advanced dementia. So no matter what I tell you, it may not work for your loved one. You have to be able to know what's going on with that loved one. I'm going to give you some hints to kind of help you clue in on what may be happening, but you're the one there with them 24/7, not me. You're there, and each person is different. Many families struggle with how to best care for their loved one with advanced dementia. What's the right decision I should make? Should I do this? Should I do that? Should I get a second opinion, third opinion? Should I go to another hospital facility? Should I do a research study? Should I do nothing at all? Individuals with the following symptoms usually have a higher chance of developing advanced or end-stage dementia, but again, no two people are the same. Memory loss. They may not be able to recognize close loved ones that they've lived with for many years. In very advanced dementia, they may, if it's your mother, she may start calling you her sister, who's been dead for 50 years. But to her, that's a comforting thought. It's a way that she's compensating. It's all that she can recall at that moment. To some caregivers, it's very upsetting. But we have to think, she has a different mind at this moment. Her mind is not working the same way. So how are we going to understand that, accept it, and grow with it to help her? They may not be able to maneuver around the house. They may not recognize familiar objects, such as a book, a fork, even their own home that they're in. They may be living in a different time, such as their childhood, their early 20s, a happy marriage, an unhappy marriage. The communication can be very variable with each patient. In advanced dementia, a conversation is often unable to occur. Now, when I say a conversation, a traditional conversation, as you or I would have, is what I'm referring to. You can still communicate, but you have to find another way to do it, because their brain doesn't work as your or I brain does anymore. So we have to find another way to do it. And I hope some of y'all have been able to find ways to do this so far. If not, we'll kind of key in on some of that tonight. Their words may sound different. They may jumble words, they may repeat phrases, they may not say anything at all. They may only make sounds, They may sing. You may find that they like to repeat music and sing music when they normally say absolutely nothing. But if you turn on an Elvis song or an old revival song, they'll light up. Not able to ambulate, perform their ADLs. They may begin to fall. When they begin to fall, that's also because of their brain. Their brain is not coordinating and communicating with their muscles and the rest of their nervous system, so they lose that sense of stability and balance. Many are wheelchair bound, but most can be bed bound. Again, each person is different. They can have contractures to the extremities. A contracture is when your muscle is not used, it begins to draw back on itself and lock into place. So then when you try to extend it, it's not able to be extended. Weight loss and change in appetite. This can be the hardest part of caring for an individual with advanced dementia, is understanding what's occurring at this point. When someone begins to lose 5 pounds, to me, that would be great. To a 100-pound individual, 5 pounds is a great deal. But in a 90-year-old individual with advanced dementia, their brain is atrophying. It is changing. It is dying. The body is beginning to shut down. So their body no longer needs as many calories and as many nutrients as we do. So physiologically, they have less need for nutrition than we do. If you try to make them eat even small, regular meals every day, you may find that they resist that. They may begin to become nauseated. They may begin to throw up because their stomach cannot process the food because their body is shutting down. In our Southern culture, where we all like to eat and we associate food with health and happy times, dementia doesn't fit very well, does it? So this is the hardest part that I've seen a lot of families have to deal with when they begin to understand how advanced their loved one's dementia is. Also, that weight loss can impact someone that is doing well. They've been communicating, they've been able to be cared for at home, but now they get a little bladder infection, they get a little confused, they try to get up out of the bed by themselves, they hit the floor, break a hip, now they have an open wound. Let's say they had diabetes on top of that. Now they have an open wound. That wound cannot heal as well simply because, number one, they have diabetes, which puts you at an increased risk of impaired wound healing. But now you don't have the groceries in your body to actually heal the tissues from the inside out. So weight loss and nutrition are a big problem in an advanced dementia patient. Any questions so far? Problems with swallowing. This also goes along with weight loss. If your brain can't communicate to the muscles and the nerves in the back of your throat how to actually coordinate the act of swallowing even your own spit, you think you might have some problems swallowing a mouthful of mashed potatoes? So at this point, you may start seeing pneumonia caused by even just your own saliva. You may see patients start drooling more. They may cough, maybe a constant dry cough. Don't even have to have anything come up. Doesn't have to be productive. A lot of times you will see patients in the hospital repeatedly with pneumonia, simply from this. Sometimes this is the first clue that patients' family loved ones have that, hey, we've got some pretty advanced dementia. And it's because family members sometimes are able to rationalize everything else because their loved one was doing well. Well, now they're not, and you're seeing that they can't cope anymore. Incontinence. Incontinence and hip fractures are often the two biggest things that will send an individual to a nursing home. Not only is it socially embarrassing for not only the dementia patient, but the caregiver, and it costs a lot, but it's more frequent and prominent than you know. This is something that many caregivers have to learn how to deal with. So we will talk tonight about how to change and breathe. Any of you having to do that currently? Did it take you a little while to begin to learn and get comfortable with doing that? And you don't have to answer if you don't want to.
It was very difficult. Very difficult.
And each person is different. Each person's body format is different. So you have to also learn. And what kind of day are they having? Are they calm, or are they not so calm? Or are they going to cooperate, or are they not going to cooperate? It sometimes can be quite interesting, we'll put it that way. Unusual behaviors. Here you can see everything from aggressive behavior, agitated behavior, traditional delirium, crying, scared, repetitive behaviors, constant rocking, constant hand motions, repetitive verbal statements, hallucinations. I will say patients with Lewy body dementia, as I'm sure y'all have been told, generally have very vivid hallucinations, like purple spiders on the wall coming to get you through the flowers in the field. Very, very vivid to them. When someone is having a hallucination, are you supposed to ignore it and redirect them to what you see as your reality, or are you supposed to react differently to that? Any suggestions?
Just this morning, my husband said he wanted to know who those people were out on the back deck. And my reaction has been to try to dispel his fears by saying there's no people on the deck, there's no bugs there, there's no cat on the bed. And I realized today that's not working because that frustrates him and it frustrates me. So I think next time he mentions something, I'll ask him what they're doing, how are they dressed. If they're cleaning the yard, then I'll be real happy.
And that's exactly what I wanted you to see, is that he's in a different reality than you and I are. So he's trying to communicate something to you. We may never know exactly what he's trying to communicate. But if you try to tell him, no, there are no children there, stop talking about the children. We're sitting here by ourselves drinking coffee. Stop it. He's only going to get more frustrated with you, and it's going to make you frustrated. Your blood pressure is going to go up. Everything's going to go haywire. So next time when he says, see that little girl picking the flowers? You say, tell me about that little girl. What's she doing? And he may tell you something else. Well, what's the little girl look like? Have you seen the little girl before? Sometimes you have to play into it for a little while, and then you're able to redirect and say, okay, let's leave the little girl there and let's go get a cup of coffee. So then you've satisfied his delusion and his moment in his reality, and now hopefully he will calmly rejoin you in your reality. And it takes a lot for you to be able to accept that and to be able to move on and learn a new way to communicate. That's part of the new communication that you have to learn. Thank you for sharing. They may be very restless due to inactivity. If they're in the bed most of the day, where during their younger years they were working on an oil field or a rig, they have all of this energy they don't know what to do with, and they can't tell you that they can't do something with this energy and they can't process it. So of course they're going to be restless. Think of them being like a 2-year-old or a 4-year-old. What would you do with a 4-year-old that now is contained to a bed with the flu? It is a horrible, miserable world for that 4-year-old. Think how it is now for an 80 or 70-year-old. So you have to just think in a different perspective. And again, each person is different, and each day is different. I just love this picture. I like cute little old men. There are different opportunities for care for patients with advanced and end-stage dementia. You can be aggressive. You can choose to do everything. Or you can care for the patient at home. You can still be aggressive while you care at home. Or you can choose some other routes. You can do nursing home and assisted living. You can do hospice care. Each person is different. Each situation and environment is different for each patient on each level of their dementia. Okay?
I have a question. What did you mean by aggressive?
We're going to get to that in just a second.
Okay. All right.
Biggest thing tonight, if you learn nothing else from me, this statement. No decision is a wrong decision if it is right for the individual and the caregiver. Because you are a 50-50 participant in this decision making. Hopefully, by the time that you agree to be the caregiver for this person, you have begun to have discussions with them to say, what would you want done if this happened? What would you want done if this happened? How did you see Mama react when Daddy had a stroke and couldn't eat? How did Mama react? How did Mama handle that? What were things that Mama expressed at that time? Okay. So even if nothing is formal on paper, there are other ways you can begin to form what Mama would want to have done at that time. Aggressive care. The caregiver and the patient decide to continue routine hospital visits, maximal medical therapy such as medications, lab work, x-rays, supportive care, doctor's visits, in an effort to prolong life and enhance the quality of life. This is where you choose to do everything. Now, for each person, your level of aggressive care can vary from the next person. It's what you've decided you want to do and that you're comfortable with. Typically, aggressive care does mean a full code status. Full code status does mean initiation of CPR. How many of you have had a discussion about CPR with your primary care doctor? That's about maybe 5 in a room of about 30, which is very typical. But you're here tonight to talk about decisions for caring for your loved one with advanced dementia, who, if they have moderate to advanced dementia, already has an expected lifespan of less than 5 years. So you have some decisions to make. And at this point, you're in the driver's seat to make those decisions for your loved one. And I'm sorry if no one has told you that before, but I'm telling it to you because I might see you at the bedside one day and have this discussion with you. I've done it many times. And sometimes I'm the first person that has ever had this discussion with a loved one and a patient. It happens. In our culture, we put things off. and we tend to wait thinking, she'll get better. We don't have to talk about this now. If you choose to do everything, that's fine. That's your choice. That's actually your loved one's choice that you're making for them. But you need to fully understand. So, are y'all okay if we talk about CPR for a moment?
Sure. Yes.
Okay. So I'm going to give you the talk that I've given patients in the hospital, and I give my patients every day. So say your loved one is an 80-year-old white female, weighs maybe 110 pounds. She's kind of humped over. She's in a wheelchair. She's not eating much. She has advanced dementia. She doesn't know where she is on a daily basis. And you're talking to me about what am I going to do with Mama. So I say, do you want CPR? And you say, sure, I want CPR. I want everything done for Mama because I love Mama and I want Mama to stay with me. Okay, let's talk about CPR. CPR is only given on patients who either cannot sustain their own heartbeat or are not breathing. Okay, so at that time, when they can't do either one of those things, then we begin giving them breaths in their mouth and performing chest compressions. As soon as we perform chest compressions on an 70, 80, 90-year-old, even 60-year-old individual, we are going to break at least 1 or 2 ribs because most individuals have a lack of calcium in their bones, and we're going to snap them. Because if we adequately want to compress the chest to help that heart perfuse blood, we have to break the ribs. You can break ribs on a 30-year-old individual. So if we can do that on a 30-year-old healthy man whose CPR was actually designed to save, not an 80 or 90-year-old, we can do that very easily on a 70 up. So, say we break a rib. Now we got this broken bone, and as we're compressing, that bone goes straight into a lung. Okay? So you've got a deflated lung now. You're giving drugs to try to get the heart rate to come back, but Mama doesn't have good veins. They're like this paper-thin skin with little bitty spider lines. So the nurse working, it's only her 3rd day on her job, and Mama's now been stuck 5 times before the resident comes in and says, oh, I'm going to start a central line, and gets a central line. So now Mama's got a line hanging out up here in her neck. So we're giving her fluids, we're giving her medications to actually make her heart start beating again. So now we have a heartbeat going again, but we still have this one lung that's not expanding because we have a rib that's stuck in. So now that we have a heartbeat again, it's not very effective, but it's there, we're going to shove a tube down Mama's throat, which already doesn't open very wide because she couldn't put her dentures in for the last 10 years. So we get this tube in there, we stick her on a machine that blows like a freight train, okay? Mama's off to the ICU. And where are you? You're standing there wanting to be right next to Mama. But you can't be next to Mama because Mama's surrounded by strangers that you've never seen before in white coats. They're sometimes very wrinkled, which is not very accepted by the geriatric population, as I might note. Sorry, that's my little joke. So, Mama's in the ICU, and you're in the waiting room. You don't know what's going on. Doctor comes out to tell you that, well, we've got Mama on about 5 different medications, and we're giving her fluids, and we've got all these machines hooked up to her, and there's bells and whistles, and we're going to watch her for the next 48 hours, and we sure do hope to get Ms. Jones through this and give her the best chance we can. 48 hours goes by. Somehow, Mama comes off the vent, somehow by the grace of God, which is how she made it onto the vent in the first place. But now Mama has pneumonia because this lung isn't working anymore. So the doctor says, well, we got her off the vent. We're going to start antibiotics now for the pneumonia. 2 weeks later, Mama's no longer with you because Mama succumbed after much pain and suffering on her part and your part. She succumbed to pneumonia. That's only one very typical scenario that I personally have seen on multiple occasions of how CPR turns out in that type of patient. I could tell you many more. I don't want to be grotesque, but that's how it can go. Now, I've also seen where CPR does work and there's no problems with it. I have to tell you the good and the bad. I would not be a good professional if I did not. But it's very rare that you get that good outcome that lasts because we're not dealing with a 30-year-old male with no health problems. So, how many of you, everybody close your eyes, if you don't mind. How many of you, before we had this discussion, would choose for your loved one to be a full code? Raise your hand, please. How many of you, before we had this discussion, would choose for your loved one to be on full code status and would want CPR done?
Full code means?
Everything, CPR and all.
Okay.
Raise your hand. And after this discussion, and hearing what CPR actually entails, how many? Okay. And that's fine. That's your personal decision for your loved one. But now you have a little bit more information that you may not have had before. Okay? It's quite different than what you see on TV.
You need to inform everyone about this.
And I do try.
I mean, everyone, the general public.
Yeah. And I do try, but it's a very personal conversation.
I mean, we don't know.
Right.
I don't know whether I want CPR. I mean, I've had some broken ribs, I guess.
Right. And you would. Are you a smoker by any chance?
No, but I'm over 70.
Okay. Your bones are probably very frail, and you probably would have some broken ribs. So, you know.
Those bones. And get a little bit scared.
Right.
Won't get you.
Yes, ma'am.
My sister, on her 80th birthday, had a heart attack, and I was living 5 hours away. So they called me. When I got to the hospital, and I picked up her hand, I could tell she was dead, but they were forcing air into her lungs, and it was going like that, you know. And I could tell it was just a machine doing it. And then they had a drip. And I could see a tiny little movement on the screen up there. Well, the doctor saw the horror on my face, and he came over and he said, "Oh, I'm so sorry, but we have to wait till you got here to sign the papers to take her off." I signed real quick.
And I will also tell you that in my experience, a lot of professionals are also as uncomfortable with having this discussion as you are. So it takes a lot for someone to be honest about this and tell you what's actually involved. And you have to be prepared for it. And you may not know until you actually have this situation come up that you need to make a decision in right then. And then what if you have 5 different siblings and you all have different viewpoints? What if you have a sibling that you haven't seen or hasn't seen Mama in 20 years that now wants to become very involved?
Or children.
That's right. So there's many different dynamics that go into this talk that needs to occur and often doesn't occur until it's too late.
I want to add something. I've had CPR training, and man, you got to push down hard.
Yes, ma'am, you do.
That, you're absolutely right on that.
And if you don't push hard enough and deep enough, there's no point in doing it because you're not going to circulate the blood like you need to. So there's no reason in doing it if you can't do it adequately to circulate that blood. That's why you're going to break the ribs. Yes, ma'am.
In the hospital, though, don't they have access to the paddles that you can bring the heart back without CPR?
Depending on what rhythm the heart is in. You don't always have to shock. Depends on what rhythm your heart is in. Depends on what's going on with the patient. And you have lots of different issues at that time. So these are just some pictures for when you're in the hospital, just things that could be going on. Care in the home. If you do choose to be a caregiver in the home, you need to be prepared to perform good body mechanics so you don't hurt yourself. You need to be prepared for stress and burnout and have ways that you can actually prevent this. Because if you can't take care of yourself, you're not going to take care of your loved one. Also, community resources. What's out there to help you take care of this person? Hospice agencies, sitters, now, all of this is out there, but what does it cost you to get them into your home? Is there a cost? Is it free? What kind of equipment do you need in your home? How are they going to take their medications? We've already identified the caregivers in the room. That a caregiver can be any person, paid or unpaid, who helps another individual with an impairment complete his daily activities for some period of time. And you really have to be a special person to be a caregiver. Not just anyone can be a caregiver. But you all are here because you are that special person. Ways to avoid stress and burnout. Find a support group. Go regularly. Find out how someone else changes a brief that makes it a little bit easier for them. So maybe you can incorporate that into your day. Take care of yourself. Go on a walk every morning, even if it's for 5 minutes. Go to your doctor's visits. Take your medication. Listen to your music. Watch your favorite TV show. Read a book you want to watch. Eat a meal you want to eat. Do something for yourself. You are an integral part of the care of your loved one. Be able to enjoy the bad times. Okay, a little quick story. My grandmother had dementia. She is a very large part of why I am a nurse practitioner today. One day we went to Walmart and she was wearing a brief. Well, she ended up having some urine on the floor in the middle of Walmart. My mother got very upset about it and didn't go quite so well. And the lady walked by and said, oh my gosh, there's urine on the floor. And at the time, you know, we were just very embarrassed. But we looked back on it after she passed, and she had the best time in Walmart that day because all these people came over to her and were saying, oh, Miss Chloe, how can we help you? Let's get you cleaned up. And it was wonderful. So just laugh at the silly stuff. You know, you gotta find fun in life. I told y'all it's a little different. Communicating with individuals with advanced dementia. They communicate different than we do. They're trying to tell us something, but it's like a puzzle. How are we going to get out of them what we want to? Touch. Power of touch is immense. Eye contact. Smiling. Don't go around looking like an old sourpuss all day. Even though they may, that may be all they can do. Meaningful listening. Don't talk at them, talk with them. Patience. Explore meaning of body language. Be able to change, be alert to changes in their response to their daily environment by what you see going on in their body. It may actually signal an acute illness. So real quickly, if I could have you stand up for just a moment. I want to show you something just real quickly. Stand up. Just come right over here. This will work. So, and this is one of the reasons why a hand is so important. So when your brain doesn't work, you have to find another way to be able to demonstrate your senses and what's going on. And oftentimes, the palm of your hand is where you're able to do that. So a caregiver would take the palm of the hand of their loved one and hold it. So if she was acting differently during the day, or kind of agitated, or had fallen the night before, but you didn't know what was wrong with her, you couldn't tell where she had hit when she fell, you hold on to her hand, and then this hand, which would be your dominant hand, would start exploring very gently. And if I got to somewhere where it hurt, then I would be able to sense in her hand that she's going to grab and sense. Have you noticed that? Okay, but you saw right here. You saw right there, you have a trigger point right there. You need a massage. That is one way that you can do it. Touch is a way you can communicate. Very effective. Even with someone that can utter not even a single sound. Thank you, ma'am.
Thank you. That's
and get down on their level. Don't stand if they're sitting or lying. Get eye to eye with them. Get into their world. Immerse yourself, as you already are, but truly get there. Body mechanics, we'll talk about over there because I'm a little behind. If you try to move them, every person is different. Pulling up in a bed, how many of you use a draw sheet? It is your best tool that you'll ever have. So if you don't currently have one, all you need is a flat sheet. You fold it in half. I like to fold it in half long ways and drape it across the bed. And as they scooch and wiggle down, you use that draw sheet to pull them back up. It saves your back. And with changing a brief, easiest way to turn them side to side. Also with turning on the side, you can use that draw sheet. Pull them to you and then gently turn with that draw sheet. Even someone that doesn't have much strength can actually move the person 2 to 3 times larger than them with a draw sheet. Now, yes, they have to have some help, but it's doable. Positioning with pillows and wedges is very important. You want to keep the pressure off of the bony areas around the knees, the ankles, the sacrum, so they don't develop pressure ulcers. This is just another example. Dangling at the bedside, you can do that. Again, the draw sheet is important, but always use gravity in your favor, not against you. Changing a brief, it's easier to do it if you have the brief and the wipes on the bed next to you instead of across the room. Just like when you were changing a toddler's brief, had to have it right there. Feeding. Sippy cups are wonderful. It allows them to still have some independence at some point, but each person is different. They may need a different type than the next person. There's many companies that supply them. You can go to Walmart, Dollar General, wherever, find some that may work for your loved one. Spoons and forks and plates that have special changes to them can help, because then they can actually compensate for the angles that their bodies need to be at to get the food where it needs to go. And also they may not have teeth. See this little gentleman, isn't he cute up in the top corner? So if you just try to ram a spoon in there, that's going to hurt. So you may need the padded spoons. Any activity that you perform does take energy. And their energy often needs to be conserved so they can do the next day's activities. Goals of care. What are you trying to do? Is it actually enhancing their quality of life? If it's not, why are you doing it? Why are you stressing yourself out and their selves? So you have to reevaluate your priorities. So often it's you that wants it done and not them. Nursing homes. What's best for your loved one? What's the financial impact? How are they going to get the care? How are you going to see them? Are you going to be worried about what kind of care they're getting? Are you going to be able to relax? If you have a spouse that now needs to go into the nursing home, can the functional spouse actually now relax and enjoy and flourish when the demented patient is taken somewhere to be cared for? Be surprised. That happens often. We talked about code status. If they do go to a facility, they're going to hopefully have that conversation with you. Hospice care. These are some basic, generalized guidelines for admission to hospice. Many patients with advanced or end-stage dementia will meet criteria for hospice because they're not going to improve. So this is an option for care of your loved one. And again, remember, no decision is a wrong decision if it's the right decision for you and your loved one. There's lots of misconceptions about hospice. Will admission to hospice mean that your loved one dies tomorrow? That's not always true. It could be, but it doesn't mean that. Does it offer a greater chance for comfort inside the home? Many times it does. Hospice generally will increase your life expectancy and quality of life in the home. Do you have to be a DNR code status? You don't have to, but it is highly recommended. But you need to be realistic about what point of the disease your loved one is at. You may still be followed in some capacity by your primary care provider, but hospice basically takes control of care. But your PCP can be involved. Hospice provides an additional layer of support. That's how we like to explain it. Someone will not be with your loved one 24/7 unless they are within 48 hours of dying, generally. And that's determined by a professional. You do have access to healthcare professionals 24/7 when you're with hospice. When you're at home by yourself with home health, you don't have that on the same level. Relationships, we've talked about performing all of the ADLs that you have to perform. We've talked about communicating. What to expect near the end of life. You're going to probably have a loss of appetite with an inability to swallow. You may have increased fatigue or sleepiness, weakness, and an inability to do tasks or any basic movements. Confusion, disorientation, changes in your breathing, increased oral secretions and sounds. That sound can be very disheartening for caregivers. Urination may or may not decline. You may have a withdrawal or a desire for the family to go away. Susie, go to the store and get a cup of coffee. I'm tired. I need a nap. That could happen. Changes in the skin color, texture, temperature. All of these are possible. It just depends on what path your loved one is on. We talked about some different ways to deal with food and water as we progress in dementia. And that is a normal part of aging with dementia. Remember to use your extended support systems. Get back in touch with that sister. As painful as it may be, she's still your sister. You know, you were blessed with her, she was blessed with you. And at the funeral, you'll very possibly see her again. And when you were children, your mama, daddy had you together. So it takes a lot to get over what's gone on through the years or set it aside for a brief period of time. I'm not saying you have to be best friends, but for you to take care of yourself and provide care for your loved one, you often have to be able to compensate and do things that you may not normally do. Try to plan funeral arrangements before you get to this point. Doesn't always happen. Be confident in knowing what your loved one's wishes are. Code status, funeral wishes, choice of a minister, dress they will be buried in prior to the time, so that when the time comes, it's much easier on you. When your loved one passes, you may see that the color of their skin changes. Their eyes may or may not close or stay open. There will be no further audible sounds of breathing, although you may hear an occasional breath for a few moments. You may, or you should not hear or see any movement of their chest wall. Depending on where you're located, if you're in the home or the nursing home or the hospital, that will determine who you call. Do you call the sheriff's office, the coroner, 911, the hospice nurse, or the nurse right outside your door? After the death of your loved one, you still continue on your journey towards acceptance. It's a long journey. It doesn't stop when they pass. If you started counseling earlier in this journey, it can significantly help you through this next step of your journey. And you can also help another who is not quite as far in their journey as you are. So then you can pass on what you've learned. I truly believe that's what we're here to do, is to help others. So, you know, as a caregiver, you have many responsibilities and many roles. But you can do this. You're already doing it. And you can continue to do it with the help of others. That's it. Any questions? Thank you all very much for your patience. I hope I've been able to help you in some way.